Hi, this is Professor Schumann, and we're going to be talking about peripheral vascular disease. Our learning objectives for this lecture are that you're going to be able to relate the major risk factors for peripheral vascular disease to the etiology and pathophysiology. You're going to be able to describe the clinical manifestations of peripheral arterial disease of the lower extremities. You're going to be able to discuss the collaborative care and nursing management of peripheral arterial disease of the lower extremities. You're going to be able to differentiate between the clinical characteristics of superficial vein thrombosis and venous thromboembolism. You're going to be able to compare and contrast the collaborative care and nursing management of patients with superficial vein thrombosis and VTE. And you're going to be able to relate the pathophysiology and the clinical manifestations to the collaborative care of patients with chronic venous insufficiency and venous lepers. So what is peripheral arterial disease? Well, you've had a lecture already on coronary artery disease. And the thing that you need to understand, we're going to talk in the next lecture that I give you about CVA, and that involves cerebrovascular disease. And what you need to understand about all three of these conditions, coronary artery disease, peripheral vascular disease, and cerebrovascular disease, is that all three of them involve the same pathophysiologic process. They all involve atherosclerosis of the blood vessels. And what atherosclerosis is, as you probably do know, it's the development of these fatty plaques in the blood vessels. So peripheral vascular disease or peripheral arterial disease involves progressive narrowing and degeneration of the arteries of the upper and lower extremities. And this narrowing is because of atherosclerosis in the majority of cases. And that atherosclerosis is the same atherosclerosis that people get in their coronary arteries, and it's the same atherosclerosis that people get in their cerebrovascular system. So when we talk about somebody, having coronary artery disease, they very most likely also have peripheral arterial disease, and they most likely have some degree of cerebrovascular disease as well. So your index of suspicion, when you're talking to a patient and they say, oh yeah, I have coronary artery disease, I've had an angioplasty 3 times, you should be thinking to yourself, I wonder what the circulation is like, to their extremities. I wonder what the circulation is like to their brain, because you really, there's no selective atherosclerosis where somebody has it to just one, particular artery. If they have it in one area of their body, they very most likely have it to all their arteries. And so you should be very suspicious if they have one type of disease, that they probably have it, in other arteries of their body. This picture here shows us the common sites of the atherosclerotic lesions. And you're going to notice when we're talking about peripheral arterial disease, on the last slide we said it's of the upper and lower extremities, but you're going to find that we're mostly talking about the lower extremities, and we don't really mention, the arms too much. And that's because the arms, they're not too long. There's not really a very tortuous path for the blood to travel from the heart down the arms. It's a pretty straight shot. But when you think about how the blood has to travel from the heart, down the descending aorta, and then look at this picture, how far the blood has to travel, and all those bifurcations or those, divisions of the blood vessels that the blood has to travel through, there's a lot of places where it can get caught up and obstructed. So usually when we're talking about peripheral arterial disease, we're talking about the lower extremities. And you can see here, those little yellow spots are the places where very often you're going to have blockages from these fatty plaques that we're talking about. The sort of interesting thing is that people don't usually have symptoms until they have about 60 to 70% blockage in those arteries. So our body, can really get by and adapt pretty well for a long time. And it's not until the vessels are really, occluded quite a bit that we have symptoms that appear. Peripheral arterial disease typically appears when people are in their 60s to 80s. So it kind of shows up, a little bit later than coronary artery disease. It's very much undiagnosed because people just don't really think about, the symptoms that they get that we're going to talk about. You'll notice that they're not, like when you get a coronary artery blockage and you have that crushing chest pain, that kind of gets people's attention. The symptoms of peripheral arterial disease aren't quite as dramatic and don't really, catch people's attention quite as much. The risk factors, though, look at this list of risk factors and tell me if this doesn't look familiar after your lecture that you had on coronary artery disease. I mean, isn't it the very same thing? Cigarette smoking, hyperlipidemia, hypertension, and diabetes. And, this is exactly what we talked about with coronary artery disease, the very same risk factors. And that's because, as I said, it's the very same pathophysiologic process that we're talking about. We're going to have a case study that we go through while we're talking about PAD. And our case study is going to involve BD, the 62-year-old man who has pain in his lower extremities when he's walking his dog. The pain that he develops is always relieved with rest. He also has a history of hypertension and hyperlipidemia. And BD smokes 1 pack of cigarettes per day. So you can see that he does have some factors there. The clinical manifestations of PAD, the classic symptom of PAD is something called intermittent claudication. I don't know if you're familiar with that term, claudication. But claudication is an ischemic muscle pain. It's sort of a crampy pain that people get when they're exercising. So either walking or, doing some sort of exercise in a gym or wherever. And the key is that they get it when they're doing repetitive exercise and that it goes away when they stop whatever they're doing and rest. And it stops, pretty quickly within 10 minutes. And it's a reproducible pain. So if they start back up again, whatever they were doing that caused the pain, they get the pain back. It's very, very predictable kind of pain. This pain is caused because they have blockage in those blood vessels that are feeding their lower extremities, and so they don't get enough oxygen. And what happens to our body when we don't get enough oxygen? What happens to our metabolism? If you think back to biology, what did you learn about metabolism? If we don't get enough oxygen, we can't have aerobic metabolism, and what do we switch to? We switch to anaerobic metabolism. And what is the byproduct or the end product, the waste product of anaerobic metabolism? It's lactic acid. And lactic acid is very irritating to your nerve endings. And so the pain that people get with this claudication is caused by buildup of lactic acid. And so they get the lactic acid and it builds up and it starts to cause pain, and so they stop whatever they're doing. And once they stop whatever they're doing, their oxygen demand goes down, and all of a sudden then they're getting enough oxygen to their lower extremities. The lactic acid is cleared, and voila, the pain goes away. So, it's a pretty simple process, really. Sometimes these people can get that ischemic, crampy pain in their buttocks and their thighs, depending on where the blockage, which vessels that blockage is in. But the key is really that it's a pain that comes on with exercise when they start When they stop exercising and rest, it goes away, and it's reproducible with that exercise. If they stop doing that exercise, it will go away. A couple of other manifestations that aren't quite as common as the claudication, but one other one is paresthesia. Now, paresthesia is a numbness or tingling in the toes or feet. It's a decreased sensation. So you kind of lose your pressure sensation, and you also lose your pain sensation. And this is very dangerous for the patient because they lose that sense of when they are getting any kind of injury in their foot. So they could be, wearing a shoe that's too tight or is rubbing wrong, and, it rubs wrong all day, and they don't they don't feel it, and so that rubs open a spot, on their heel. And they don't know it, so they take the shoes off, go to bed. Next day, they put the shoes on again. They don't know that the shoe wasn't fitting properly, and wear the shoe again. And after 2 days of rubbing, the area is rubbed open, and before you know it, you have a weeping open sore, and they don't even notice because they don't have that feeling there. So it's very dangerous. Some of these symptoms of PAD. Some of the other clinical manifestations are thin, shiny, and taut skin. So the skin on their lower extremities will be very, very shiny. They will lose the hair growth on their lower legs. Very commonly, they'll have diminished or absent pedal, popliteal, or femoral pulses. Their foot will get very pale when they raise it up. So they sit down and put their feet up. Their feet will get very pale looking. And they may have reactive hyperemia of the foot when it's in the dependent position. And hyperemia means that the foot gets very red. They can also have pain at rest, which can occur in the foot or toes. This pain can be aggravated by limb elevation, and it occurs from insufficient blood flow, and it occurs more often at night. And so people will commonly, develop this pain while they're laying down in bed. They'll sit up, hang their feet over the side of the bed, to try to relieve the pain, and try to maximize the blood flow to their lower extremities. So they're, very restless sleepers. Back to our case study, you're assessing BD, and you find that his feet are pale and cool to touch. He has diminished pedal and posterior tibial pulses and decreased sensation. He has a small open area on the lateral side of his left ankle. Now, anytime that you find you can't feel a pulse in a patient's foot, what you should do is find the Doppler device on the unit. All units usually have a Doppler device, and this enables you to hear the pulse rather than feel the pulse. It's very common, as I said, that the pulse will not be palpable any longer because of the decreased blood flow. But if you use a Doppler device, and you have to really goop it up with plenty of the gel that comes with it, you will very oftentimes be able to hear the pulse. And then you'll mark that spot with a pen or an indelible marker so that everybody can know where that pulse is. If you don't even hear a pulse, that is not a good sign, because that means that there's probably no circulation to that extremity, and that is not a good thing. Some of the complications that can develop from PAD are atrophy of the skin or the underlying muscles. Of course, the patient has delayed healing and can develop wound infections very easily because of this decreased blood flow. They can also develop tissue necrosis and very commonly can develop arterial ulcers. Non-healing arterial ulcers and gangrene are the most serious complications, and if these aren't caught and treated, they may result in amputations. If the adequate blood flow is not restored, or if severe infection occurs, which sometimes happens, you just can't get the infection under control. And so sometimes the patient ends up having to, have a couple of toes, part of a foot, or even the whole, leg below the knee amputated. And this is, certainly very difficult for them. The diagnosis of PAD is pretty simple, really. They really only have to have an ultrasound and just, where they just take the probe up and down the leg and look at the extremities and the blood flow, and they can see pretty quickly whether the blood flow is adequate or not. They can also do a test called an ankle brachial index, and this is done with a handheld Doppler, and they compare the ankle pulse to the brachial pulse, and you take the ankle systolic blood pressure and divide it by the higher of either the left or the right brachial systolic blood pressure. The normal ABI is between 0.91 to 1.30, and that indicates an adequate blood pressure to the extremities. An ABI between 0.71 and 0.90 indicates mild PAD. Between 0.41 and 0.70 indicates moderate PAD. And an ankle brachial index less than 0.40 indicates severe PAD. They can also do angiography, which is, of course, when they inject dye into the blood vessels and can watch the actual blood flow. And MRIs can also be done to watch the blood flow of the dye they've injected. These are very helpful in highlighting exactly where the obstruction is. And a duplex study is where they go and look at both the flow in both directions, and they use a color Doppler, which helps them see arterial and venous blood flow. If you get to go with your patient for any of these studies, it's really, really interesting. So make sure that you take advantage of that. Back to our case study again. BD goes for an angiography, and he has nearly completely obstructed vessels in his lower extremities. So he is diagnosed with peripheral arterial disease. What treatment plan do you anticipate? Well, we'll have to see the extent of his disease to see what kind of treatment plan they'll go with for him. So let's look at the slide. Of course, the first thing, you're going to look at his risk factors and try to modify those. And it's difficult because here's a man with 4 risk factors, and they're going to go in there and say, okay, you want to stop smoking, we're going to treat your hyperlipidemia, we're going to treat your hypertension, and we're going to treat, well, he's not a diabetic, I don't believe, but he has 3 of the 4 big risk factors. And change, of course, is very hard for patients. And when you go in there like a bull in a china shop and tell them all the things they need to change, it can be very difficult. So sometimes you sort of have to pick your battles and talk to the patient and say, which one of these things do you think you could change right now? And let's just, take one at a time because it's very difficult. And you really want to involve the patient and let them have some choice in the matter, because if you don't, you're probably not going to get them on board for any of the changes. Usually, treatment of hyperlipidemia is going to involve diet, first of all, and if diet isn't effective in bringing their lipids down low enough, then they'll try medications. Blood pressure, of course, they're going to recommend exercise. They're going to recommend weight loss and then medications. And we're going to talk about diabetes in a couple of weeks, and you'll find that the glycosylated hemoglobin is a way of looking at what the patient's blood sugar has been like for the whole past month. And so looking at a glycosylated hemoglobin tells you how well their diabetes has been controlled, and they like it to be below 7.0 for diabetics. So, you're going to look at that reading and see whether they've been managing their diabetes well or not. So the medications that they're going to put patients on who have PAD are going to be, a number of different agents. They're going to put them on ACE inhibitors, and these are the drugs that end in the pril, P-R-I-L. You can see the suffix right here. And what these drugs do is they increase peripheral blood flow. They increase the ankle brachial index. They allow the patient to walk further. And what they do is help to reduce the circulating blood volume in the body, so therefore the heart doesn't have to work as hard, and it can circulate the blood better. They're put patients with peripheral arterial disease on antiplatelet agents, and usually this involves aspirin, and oftentimes it also puts them on, or they put them on a drug called clopidogrel or Plavix, and you probably heard of this drug. They won't always put them on Plavix, but very often they'll be on Plavix after some sort of intervention. If they have angioplasty or stenting, they'll put them on Plavix for a period of time afterwards. The antiplatelet drugs, what they do, if you remember from anatomy and physiology, platelets normally, the way they work is they go to the site of an injury, that they're the first line of defense, and their surfaces are very sticky. I kind of like to think of them like Velcro. And so they all rush to the site of an injury, and what they do is they all sort of bump into each other, and they end up sticking together and piling up on top of each other and sort of building, a big clot. And so what these antiplatelet agents do is they change the surface of the platelets and make them slippery instead of sticky. And so that when the platelets run into each other, they're not able to stick to each other. They just sort of slide off of each other. And so that's great when you don't want clots to form in the blood vessels and block off, blood flow. The downside of it is that when you have inadvertent cuts or any kind of invasive thing that breaks the skin, like even if you go to start an IV, and you break the skin, you're going to have excessive bleeding because you're not going to have the normal coagulation that normally occurs. So you have to really watch these patients for abnormal bleeding and be really careful. They're at high risk of injury because of the medications that they're on. Other drugs that will be ordered for treatment of the intermittent claudication, and what these drugs do, it depends on what particular drug, but there's a drug called Pletol, and that also inhibits platelet aggregation, also increases vasodilation. Another drug that's been around forever is a drug called pentoxifillin or Trentol, and it increases erythrocyte flexibility and decreases blood viscosity. And that's been prescribed, I think, almost as long as I've been a nurse for patients who have PAD. Case study again, BD has ordered the following drugs. He's ordered aspirin. He's ordered a lipid-lowering agent, which is Zocor. He's ordered an ACE inhibitor. We know it's an ACE inhibitor again because of the pril. And he's ordered Trentol, 400 milligrams TID. Now, the exercise therapy that is prescribed for PAD helps the cells learn to extract more oxygen in the legs. So these patients are really advised to walk. As you know, walking is good exercise, for anybody. And patients with PAD are really recommended that they walk 30 to 60 minutes daily, at least 3 times a week. And this will really help their bodies learn to, utilize more oxygen. And they can also walk on a treadmill. They can, walk outside. They can walk in the mall. They can really walk anywhere they want. Nutrition therapy is important. They really want them to keep their BMI below 25, which that's hardly anybody these days. So the waist circumference, they prefer that men keep it below 40 inches and women below 35 inches. So they recommend, a healthy diet, high in fruits, vegetables, and whole grains, low in cholesterol, saturated fat, and salt, which, that's a healthy diet for everyone. And they really want people to consult their healthcare provider before they're taking any kind of herbal supplements, because these can interact with a lot of the medications they're on. So they should really not take, over-the-counter dietary or herbal supplements without checking with their healthcare provider. Now, there's several things they can do if the patient has a critical limb ischemia, meaning that, they have very, very limited blood flow to the point that they could possibly lose their limb if they don't improve the blood flow. There's several types of surgeries that can be done to improve the blood flow. You obviously want to protect that patient's limb from trauma. We also want to decrease their ischemic pain, prevent infection, of course. We want to improve arterial perfusion, and some kind of new strategies that they're researching. One of them is spinal cord stimulation, which they're working on to help manage the pain and to also help prevent amputation in some of these patients who have critical limb ischemia. Angiogenesis is the growing of new blood vessels, and they're doing a lot of research with gene therapy and other things to stimulate, new blood vessel growth. And some of that is showing a lot of promise. So back to our friend BD, he returns for follow-up in 3 months. His blood pressure and lipid levels are stabilizing, but he still complains of increasing leg pain, at rest even, and his physician determines that it might be time to consider an intervention to improve his circulation. Now, just like, we've gotten with the heart, where everybody doesn't need bypass surgery, that there's a lot of other options besides that. So it has happened with extremities, that we can do a lot of more less invasive types of procedures to circulation. And most of these procedures are done in interventional radiology. And the indications are intermittent claudication symptoms that become incapacitating, or pain at rest, or ulceration or gangrene that is severe enough that is threatening viability of the limb. So I don't know if you guys know that gangrene will appear as a black spot on the patient's limb. So they could have a very nasty looking ulcer, or they could have a black spot in the middle of an ulcer, and that's when you really become concerned, because that indicates that they have some very critical need for blood flow to that area. So some of these procedures that can be done in interventional radiology are really similar to what's done, in the heart. Percutaneous transluminal balloon angioplasty, or PTA, involves the insertion of a catheter through the femoral artery. Instead of feeding it up to the heart, they're going to feed it down the limb to where the critical blockage is. There is a balloon at the end of the catheter, and when they get to the blockage, the balloon is inflated, and that dilates the vessel and sort of pushes the atherosclerotic plaque away, and then they'll usually put in a stent to keep that plaque, pushed aside. An atherectomy is another procedure that can be done where they actually remove the obstructing plaque. And this is performed again by using a catheter through the femoral artery and feeding it down the limb to where the obstruction is. And then there's a cutting disc or laser, some sort of device on the end of that catheter that can cut the plaque and remove it. Cryoplasty is a procedure that combines angioplasty with cold therapy, and they use liquid nitrous oxide to actually freeze the plaque, and that actually makes the plaque, sort of shrivel up eventually. If these procedures aren't successful, or for some reason they don't think they'll be successful, then there's always surgery, which is more invasive, involves anesthesia, involves big incisions, so a longer recovery time, more risk for infection, just involves a lot more, but it is another option for these patients. And what they can do is bypass where that blockage is and either use a graft with a part of the patient's own vein, or they can use a synthetic graft and bypass blood around that lesion, around that blockage, to get blood lower down in the extremity. And this kind of surgery has been done for years and years and years. This used to be the only option. And so they would do, tons of surgeries. The most common one was called a femoral popliteal bypass graft. So they would start at the femoral artery, which is up here, and they would bypass, like here, this whole yellow plaque here is obstruction. So they would bypass all of that with, now they have synthetic grafts, but they used to use, they would, use some sort of the patient's own artery that they removed from some other place, and they would bypass all the way down to here to get blood flow down to the foot, and the lower leg. And this has been done, again, as long as I've been a nurse, and that's almost 40 years. So this is not anything new. What's new are the procedures, like the angioplasties and the stenting and some of those other things. Other surgical therapies, an endarterectomy is basically going in, opening up the artery, dissecting down the artery, cutting down the artery, and removing the plaque, and then sewing up the artery, and then sewing up the skin. So it's a big incision again, and a lot of risk for infection, and longer recovery time. A patch graft angioplasty is where they open the artery, remove the plaque, and then sort of patch up that spot to widen the lumen of the blood vessel. And then, of course, last-ditch approach or last-ditch surgery would be amputation. And if the tissue necrosis is extensive, If gangrene or osteomyelitis is developed, then they really have no choice. And they'll do an amputation if it's absolutely necessary. And sometimes, unfortunately it is, depending on the extent of the patient's disease. What do you want to assess when you have a patient with PAD? Well, of course, you're going to be assessing them for all the risk factors: diabetes, smoking, hypertension, hyperlipidemia, obesity. You want to find out, which of these risk factors they have in their history. Ask them, if they have exercise intolerance. Do they have loss of hair on their legs and feet? You're going to assess whether they have decreased or absent peripheral pulses in their lower extremities. So our friend BD undergoes bilateral PTA with stenting. What nursing diagnoses are appropriate for him? And what goals would you develop for him post-operatively? Well, we're going to help you out with that by some of the nursing diagnoses. Of course, impaired skin integrity. He's had a catheter inserted through his femoral artery, so his skin integrity has been compromised. And activity intolerance. We hope we're going to improve that, but we don't know yet. Ineffective self-health management for all of his risk factors. And of course, ineffective tissue perfusion. That's his main problem. That's what's got him into trouble. The goals for someone who has PAD, of course, we want them to have adequate tissue perfusion. We want to relieve their pain. We want to increase their exercise tolerance. And we want their skin on their lower extremities to be intact and healthy. Health promotion activities that we're going to undertake for this patients like this. First of all, identify who's at risk. Diet modification, proper foot care, avoidance of injuries. Another appropriate diagnosis for our patient in this case study would be risk for injury, because if he has any paresthesias, he apparently did, because he did have a sore on his foot, he's not going to be aware that he has that happening. So BD comes to the recovery area after his angioplasty. He has bilateral dressing on his groins, and he is positioned supine. We're going to frequently monitor him after surgery. And the things that we're going to be monitoring are his skin color and temperature, capillary refill, the presence of peripheral pulses distal to the operative site, sensation and movement of his extremity. And we're going to be checking those very frequently right after surgery. And then as time goes on, less often, but continue to monitor them. After he leaves the recovery and goes back to his unit, you're going to continue to assess perfusion to that lower extremity. You're also going to be assessing for complications, which could be bleeding, hematoma, thrombosis, embolization, and compartment syndrome. Compartment syndrome is something that we'll talk about later in the course. You want the patient to avoid knee-flexed positions, except when they're exercising. So prolonged knee-flexed positions are not good. You want them to walk short distances. Even if they need a walker, they need to, get moving as soon as possible. And you want to turn and reposition them very frequently. Get them moving. So BD is being discharged home. What will you teach him regarding immediate care and precautions at home? And what patient teaching is essential for him to help manage his disease? You want to remind him when he goes home, what is he going to do with those risk factors? And, maybe you've decided, you and he together have decided he's going to work on smoking cessation. And, he's going to leave the diet for right now. I mean, you can't expect someone to drastically change their diet, give up cigarettes, start taking blood pressure medicine, do everything. I mean, I don't think you can. I think you have to give them a chance to sort of gradually, change a few things at a time. He's going to be on long-term aspirin therapy. You want to talk to him about the importance of gradual physical activity after surgery. And you want to explain about the activity that it's going to help with a number of cardiovascular risks. Heart risk, cerebral vascular disease. It's going to help with a variety of risk factors that he has, so it's probably a good thing for him to get exercising. You want to remind him that meticulous foot care is important. These patients should inspect their lower extremities at least once a day. And, use a mirror to look at the bottom of their foot, the back of their leg, the places they can't really see on their own. Because they may not have good feeling, and that may not come back. So they really need to be proactive and really inspect their feet. You should wear comfortable shoes with rounded toes, soft insoles, and don't tie them up super tight. Tie them, so that they're comfortable. You're going to have a lot more trouble with the ladies who might want to wear high heels and, real fashionable shoes. But you need to get them to wear something that's comfortable and that isn't going to cause a lot of skin breakdown. So I have a question for you guys. A patient with peripheral artery disease has marked peripheral neuropathy. An appropriate nursing diagnosis for the patient is risk for injury related to decreased sensation, impaired skin integrity related to decreased peripheral circulation, ineffective peripheral tissue perfusion related to decreased arterial blood flow, activity intolerance related to imbalance between oxygen supply and demand. Well, we haven't been told anything else other than the fact that he has marked peripheral neuropathy. So we know that he's at risk for injury related to decreased sensation. At the moment, we don't know that he has impaired skin integrity because we don't have any evidence that he has any kind of breakdown. We don't know that he has ineffective tissue perfusion because we haven't been told he has a decreased pulse. And we don't know if he has activity intolerance because we haven't been told that he has pain. So the only one we really have evidence for is A. Here's one more for you. The nurse teaches a patient with peripheral arterial disease. She determines, or he determines, that further teaching is needed if the patient makes which statement? So these questions are always a little tricky because they're asking you to identify the incorrect statement. Further teaching is needed. So the patient is saying something wrong. So you have to look at each statement and constantly remind yourself you're looking for the wrong statement. So A, I should not use heating pads to warm my feet. Well, that's a true statement. We don't recommend that anybody use heating pads because of the risk of burns. So A is not the correct answer because it is a true statement. It's further teaching is not needed because it's a correct statement. B, I should cut back on my walks if it causes pain in my legs. Well, I said that exercise was really, really important for these patients. So let's hang on to that answer for a little bit. I will examine my feet every day for any sores or red areas. Well, I said that was really important. So that sounds like a true statement. There's nothing wrong with that. So let's eliminate C. D, I can quit smoking if I use nicotine gum and a support group. Well, that sounds true. doesn't it? So that would mean that B, I said that exercise was really important, and we didn't really say anything about telling the patient to stop if it causes pain. So I think that B is the right answer. And actually, according to the book, B is the right answer. Patients should be taught to exercise to the point of discomfort. Then they can stop and rest, and then resume walking until the discomfort recurs. So they shouldn't cut back on their walks. They can just stop, for a minute or two or rest. But this is sounding like the person's going to stop the walking completely, and that's not what we want them to do at all. All right, we're going to move into talking about peripheral venous disorders. What we were talking about before was peripheral arterial disorders, and now we're going to get into talking about peripheral venous disorders. And these are really divided into two things: venous thrombosis, or a clot, and chronic venous insufficiency, or what we were talking about with decreased blood flow, but this time it's going to be chronic venous insufficiency rather than arterial insufficiency. So superficial vein thrombosis is the formation of a thrombus in a superficial vein, usually the greater or the lesser saphenous vein. Now, we used to think that superficial vein thromboses weren't really that much of a big deal. We were much more concerned with the deep vein thrombosis than we were the superficial vein. Now they're thinking that, well, maybe these superficial vein thromboses are a little bit more important than they thought before, because they may indicate that in 25% of patients who have a superficial vein thrombosis, they may also have a deep vein thrombosis, or a VTE, at the time of diagnosis. So that's what's bad about them. Now, a venous thromboembolism, a VTE, this is the new term. We used to call them DVTs, and they just decided a more correct term was VTE. So I'm going to try to use the new term, but it's hard to teach an old dog new tricks, so give me a little bit of a break if I screw up. There's a cluster of symptoms, or a cluster of risk factors that cause venous thromboembolisms, and they are broken down into 3 different factors, and those factors were described by this guy named Virchow, and so they've named the factors Virchow's triad. And so when you want to think about, well, what are the risk factors or the causative factors for VTEs, you can break them down into 3 main categories. And that kind of helps you remember, well, what are the risk factors? And these 3 main categories are venous stasis, so, blood flow not happening, just blood sitting there, not moving. Hypercoagulability of blood, meaning the blood is hyper thick, it's wanting to coagulate really badly, really wanting to form clots. And then thirdly, endothelial damage. So damage to that inner layer of the vein, that intimal layer, that very inner layer. So under the next 2 slides, I've put all the risk factors that fall under them. And so you can kind of, they make sense, they're pretty logical. All the things that can cause venous stasis. Somebody who's heavy. If you've got a big fat abdomen, sitting on your femoral arteries and veins, you're not going to have real good blood flow to your lower extremities. And the same with pregnancy, although it's a more of a temporary problem. Somebody, you're sitting on a plane for an 8-hour flight to Hawaii, or a 12-hour flight to Australia. A prolonged surgical procedure, somebody who is strapped down on an OR table for 12 hours because they're doing, brain surgery or something. Their blood's not flowing all over the place like it's supposed to. And our patients who are in bed, on bed rest. This is why we don't like them to be on bed rest for a long period of time, because their blood just lays there and it really wants to clot. And then those clots want to move around and do bad things in our lungs. Things that cause the blood to be hypercoagulable: anemias, cancer. Cancer just in general causes the blood to be hypercoagulable. Sepsis. Sepsis is a severe infection, and that causes the blood to be very hypercoagulable. Oral hormone therapy, such as oral contraceptives. This is the problem with women taking oral hormone therapy. They are at higher risk for developing blood clots. This is another risk of smoking besides the problem that it causes with your lungs and the vasoconstriction that it causes with your blood vessels. So it's not just one thing that smoking does, but several things. And the endothelial damage can be caused by abdominal or pelvic surgery. It can be caused by a caustic IV medication. It can be caused by IV drug abuse. It can be caused by us in the hospital putting in a PICC line. It can be caused by a previous venous thromboembolism. It can be caused by fractures of the pelvis, hip, or leg. So all of these things are all risk factors for venous thromboembolism. You can see how many different risk factors there are. So the clinical manifestations of a venous thromboembolism, and this is if you're lucky enough to have a symptom. Many people don't have any symptoms. But if they would have unilateral leg edema, pain, or tenderness with palpation, a dilated superficial vein, a feeling of fullness in the thigh or calf, a paresthesia, again, that is a numbness or tingling, warm skin or erythema. Erythema, if you don't know what that is, it's a redness. Sometimes people will actually have like a flushing red skin over where a venous thromboembolism is. A systemic temperature above 100.4. How do we diagnose a VTE? Kind of simple. Ultrasound. Plain and simple. They bring in an ultrasound probe, run it up and down the leg, and they can see very quickly if there's a thrombus in there. So when they suspect a VTE, they order a stat ultrasound, and very quickly they will determine if there's a thrombus in there or not. It'd be nice if they could just go in there, and inject the thrombus with something that just blew it apart, but it's not that simple. We do have clot busters for thrombi in the heart, but we don't really use them on peripheral thrombi. So for the most part, we give the patients heparin. Now please don't call heparin a blood thinner, because that's a layman's term and it's really not what heparin does. Heparin is an anticoagulant, or an indirect thrombin inhibitor if you want to use the really correct term. But anticoagulant is fine. And what heparin does is reduce or prolong the amount of time it takes for coagulation to occur. So what heparin does is prevents more clots from developing. It does nothing for that clot that is already there. And any of these drugs that we give, that's all they are doing, is preventing new clots from developing. The only thing we can do to handle clots that are already there is to go in and operate and open up the vein and take out the clot. And that's called a venous thrombectomy. And that's not an option for too many patients. It's a very, invasive procedure. And usually patients will be okay if we give them heparin and we just kind of keep them. We don't want to keep them on. We used to keep them on bed rest. We were so afraid that clot would break off and travel to their lungs. And we don't do that so much anymore. We do let them get up and move around, but we don't have them do any vigorous exercise. We kind of, keep them fairly still. We keep them on heparin. We monitor their PTT, their partial thromboplastin time. And then we transition them to oral medications that do the same thing as heparin. Now, we used to just have one oral medication that we could transition them to, and that was warfarin or Coumadin. And over the last, 5 to 10 years, the drug companies have gone crazy with developing drugs that are like warfarin, but don't require monitoring of any blood values. So if you, watch any TV, you'll see Xarelto, Arixta, and Evista, Evista is the other one. They are advertising like crazy that they're so convenient because patients don't have to have blood tests. And that's true. And in studies, they have been just as effective. So, that's great. The problem is, as I mentioned earlier with the antiplatelet agents, if we're anticoagulating somebody, what's going to be the problem or the side effect that we're going to have to worry about? Bleeding, of course. So we have all these, particularly we have older patients who are all on warfarin or Xarelto. And what do they tend to do, our older patients? They're clumsy, they're confused, they're off balance. They do have more falls than the younger people. And a lot of them tend to hit their head when they fall. And what happens when they hit their head? Well, they have trauma in their brain and they start bleeding. And because they're on Coumadin, they continue to bleed. And sometimes the bleeding goes on and on and on, and it's a serious problem. So one of the first things an ER doctor will ask a patient who comes in with a fall, are you on any anticoagulants? Because he just sort of is in trepidation of a patient who is on anticoagulants and has just fallen. And you have to look at all the other spots where people can bleed as well. You're going to watch their urine for blood. You're going to watch their stools for blood. If they have any kind of bleeding gums when they're brushing their teeth, they need to report that. Any kind of abnormal bleeding. If women are not postmenopausal and they have real heavy menstrual bleeding, they need to report that. So these drugs, are great in some ways, but sometimes the side effects are worse than the cure. So here's kind of what I was saying. You don't want to give them any IM injections. These patients should use electric razors rather than, the straight razor. They usually give them a stool softener so they're not straining to have bowel movements, and that way they hopefully won't bleed. If you have to give them any, put any tubes in, You want to make sure you lubricate them really well. You want to try to minimize any venipunctures that you might have to, do for them. Any mental status changes you want to be very aware of, because this could indicate something going on in their head. As I said, you're watching urine, stool for blood, nosebleeds. VTE prophylaxis is a core measure of high-quality health care in hospitalized surgical patients. I don't know if you know what a core measure of high-quality health care means, but, with everybody and their brother getting involved in health care and quality health care, we now have quality measures. These are things that have been proven to improve the health of patients. And so core measures are things that are without a doubt proving to be beneficial to patients. And in this case, we're talking about hospitalized surgical patients. But you'll see most of your patients who are in the hospital and who are going to be on any kind of bed rest or mostly spending time in bed will have these core measures instituted as well. And it's really just good nursing care. But somebody decided that we had to call it a core measure and, make sure that it was being done. So it involves changing positions every 2 hours for anybody who's immobilized, ambulating the patient 4 to 6 times a day, anti-embolism stockings, which are TED stockings, making sure these patients are on some type of anticoagulant therapy. It could be heparin. It could also be Lovenox. And using sequential compression devices, or those foot pumps, or SCDs, or they call them all sorts of things at different places. But the things that compress their legs, and that helps to, with the venous return. All these things are required for a hospital to claim that they are providing quality health care to their patients. As far as patient teaching, when a patient is on anticoagulant therapy and they're going to be going home on anticoagulant therapy, you want to tell them to take their medication at the same time every day. If they do need blood tests to monitor the therapeutic effect of their medication, you want to emphasize to them how important it is that they do that. Remind them to monitor themselves for signs of bleeding. They shouldn't be doing any kind of activity that's super risky. They shouldn't be taking any aspirin or NSAIDs because that increases the risk of bleeding as well. They should only drink small to moderate amounts of alcohol. They should definitely have a medical alert bracelet that informs people that they are on anticoagulant therapy. Rather than telling them, to eat a certain item that has a lot of vitamin K or doesn't have a lot of vitamin K, they should kind of maintain a steady diet and not add or subtract anything to their diet and keep it pretty consistent. And make sure that all their healthcare providers, including like the dentist, knows that they're on anticoagulants, or he might be a little surprised, at how much bleeding they have when they're just even doing a dental checkup. And that is it for peripheral vascular disease. If you have any questions, you may email me, and I'll be glad to try to answer them for you.